respected chairpersons and honorable delegates present here. On the very first day, uh, one of our members, Dr. Rajiv Khandekar, who was in Oman, as well as who is attached to John Hopkins Hospital on Public Health Ophthalmology, has rightly pointed out that in this beautiful meeting of APAO Congress, there is no session on low visual aid. But lucky enough that we the Aquanians have got the pleasure to have this particular session here, keeping pace with the directive of our president of this year, Professor Lalit Nepalia, who has taken the academic theme of the year of Aquan on low visual aid starting from October 2024 again to 30th of September 2025. Everywhere we are assembling, we will just concentrate our all discussion on low vision aid. So let's look on the particular necessity of understanding low vision aid for the community at large. You all know the common diagnosis in our low vision clinic, whether so many retinal problems or whole goal problem or optic nerve problem like glaucoma, corneal problem like corneal scar, lens problem like cataract and pseudophakia, cortical problem like cortical blindness and others. Tipping to our view on the clinical profile of patients attending our LVA clinic, we can jolly well see that most of the LVA problem is concentrating on retina, and then on the other aspects, whole globe, optic nerve, cornea, lens, cortical, even lens. But most of the problem lies on retina, more than 63%. Coming to the causes of low vision in India, amblyopia tops the list. Then optic atrophy, glaucoma, corneal disease, higher visual pathology and congenital eye anomaly, and ophthalmos retinal disease. To give effect to the United Nations Convention on the Right of Persons with Disabilities in the year 2026, 8 subcommittees were formed with locomotor disability, deaf and dumb, intellectual disability, so also. But blindness and low vision is one of those 8 subcommittees. And the Ministry of Social Justice and Empowerment has revised the definition of blindness and low vision rights of Persons with Disabilities Act of 2026. As per this, we have made the guideline of our low vision aid on 1st June 2001, where so many categories had been done with the vision in better eye and worse eye with so many percentage. I do not like to go into all those. The feedback and problems of with all those previous definition as narrated in 2001, that many patients falling in between 40 to 75%. Many patients not fitting within option. It was difficult for the doctors to declare any patients visually handicapped. So this was. That's why we have prepared a beautiful disability matrix and go through this disability matrix, and we can jolly well prepare the disability of that particular person, and we can give them the proper percentage in one column for the right eye, in the other column for the left eye, and in that way, keeping this very simple disability matrix in your chamber or your office, you can declare any patient as a visually handicapped or not. But one thing very clearly I would like to tell you, that this particular line should be keeping in mind, that after proper refraction or any operation, if the vision is not improved up to the mark, then and then the patient will be declared permanently visually handicapped, otherwise not. And these are the disability matrix and distance equity, and the percentage, suppose in the right eye is 160 and left eye is 660 in the better eye, so you will have 660. So this is the disability matrix, and 60% disability is, as per the present guideline, would be enabled to get some vision or not. So these are all these things. And the field criteria is another criteria for disability apart from visual acuity. So this is less than 40 degree, less than 20 degree, less than 10 degree visual field will also give some weightage for visual disability. Here is that matrix for visual field defect. And person with benchmark visual disability means a person with not less than 40% of disability. And the patient must have some field loss and also some vision loss. The greatest impairment of either is to be used for criterion of overall visual disability. And there may be temporary or permanent. Temporary, suppose with cataract and other. Temporary, but after operation, he will again be adjusted whether he is fit for permanent or not. So these are all these schemes, and benefit for visual disability has been all changed right now in the year 2017 by Department of Social Justice and Empowerment of the Goal. And this vision is a multifactorial, multidimensional, distant vision, near vision, color vision, stereopsis, contrast sensitivity, ocular motility and ocular reflexes. You all know all these things, and these are the milestone of development of the eye. So also, and the successful networking with education department is the first and foremost thing of our visual disability management. So our takeaway message is very simple. The meticulous history taking of the development of the vision, genetic counseling, prenatal diagnosis, good postnatal care, multidisciplinary approach, early detection and introduction of low vision devices, and preparing individual education plan and overall certification to get some job or anything like that. So these are the very key points to keep it in mind when we will discuss on low visual aid and low vision in the community. Thank you very much. So please go on with follow-up services, rehabilitation services, awareness and demand generation, providing barrier-free access, use information technology, setting up linkage, and making low vision devices affordable and accessible to the masses. That is a must. What Dr. Parikshit Gogate will narrate in his lecture, what he is doing beautifully in Pune, Maharashtra. So I am happy to say we have got 18 state chapters right now of equine in India. Through these state chapters we are working everywhere, and for the coming 3 months, every weekend, we will assemble in one of these states in India to discuss on low vision aid, low vision aid, low vision aid. Coming week, we will be in Jaipur, week next in Shivmoga in Karnataka, and in the last week at Kurukshetra in Haryana. In the May also, we will be in Datia in first week, second week in Hyderabad, third week in Jharkhand, like that. For 18 state chapters for coming 18 weeks, and we will be all over India. And lastly, on 31st October, 1st and 2nd November, please be kind enough to be at Himachal Pradesh and join in our annual meeting there. In that way, our activities will go on for the community with low vision. Thank you very much. Wish you a blissful day.
Thank you, Dada, for a wonderful keynote address. You have virtually covered all the key points in relation to this oration. I would request you to make a brief summary of your presentation and circulate it either on the social media or as a hard copy to all the members of our ECOIN. Professor Praveen is also nodding his head, so that means this also bears his consent also.